Good morning, everyone. I am happy to welcome Dr. Pratap Duggirala sir, Professor Plastic Surgery. I am myself Dr. Nareshkumar, Assistant Professor Plastic Surgery. Today we will discuss the topic case study of 1 year follow-up on quality of adherent scars after autologous fat grafting processed by a filtration technique. Published by Daniel D. Richpama and Mariel E. Jaspers in the Journal of Burns, 2024 December edition. The background of the study: adherent scars are result from damage to subcutaneous layer, causing stiffness, pain, functional and aesthetic issues. Autologous fat grafting restores subcutaneous layer, improves scar quality. Multiple fat processing technique exist. Example: centrifugation, decantation, gauze rolling, and filtration techniques. Centrifugation is the most frequently used. Previous histological studies shows filtration claims a higher adipocyte viability, more contaminant removal. The gap between the study was few long-term clinical studies comparing filtration outcome in scars. Study objective. The aim was to assess the long-term scar quality changes after the autologous fat grafting processed by filtration technique in patients with adherent scars. Hypothesis of the study: filtration process autologous fat grafting improves scar quality, which is measured based on patient and clinician assessment and objective measures. The study design is a prospective cohort study of long-term effect of single treatment of autologous fat grafting processed by filtration technique in adherent scar. Location was in Burns Center, Red Cross Hospital, Netherlands. Inclusion criteria are adults greater than 18 years with adherent scar indicated for adhesive lysis and autologous fat grafting. Timeline of the study is November 2014 to December 2018, 2024. Follow is baseline 20 photograph 24 hours pre-operatively, post-op 3 months and 12 months period. Study protocol same as previous study by centrifugation. So, sir, in this view of the study, in your experience, when is autologous fat grafting most effective for adherent scars?
So here, since the topic has been chosen that it is only for adherent scars, I personally prefer doing it only after they have become mature. That means the initial, when the immature, angry, red scar phase, when there is still some amount of healing phase, I don't want to disturb it. I wait at least for 6 to 9 months after everything has healed, and only after I feel that the scar has become mature, I will go to the next step.
How does autologous fat grafting compare to other surgical scar release technique in terms of long-term outcome is useful?
So basically, previously we used to use only subcision technique for adherent scars. After we have started using fat grafting for numerous other techniques like breast, face, etc., we found benefits of this fat grafting technique and we started using it. I don't think we have so many numbers that we can say with surety that this is 100 times better or this much better, but we hope that after we create a plane by subcision or whatever technique and we inject some fat, it creates that extra viable tissue and maybe it helps in faster healing, and that having that extra viable tissue will ease that patient suffering, pain, whatever is there.
Okay. So intervention details. The under regional or local anesthesia, abdomen, flanks, or thigh with small incision after tumescence infiltration. was harvested. 500 ml tumescent infiltration, 500 ml NS with 20 ml 1% xylocaine, 1 is to 2 lakh adrenaline. Harvested with negative pressure by 50 ml Luolox syringe, pure graph investing cannula. On processing pure graph filtration system, 50 ml container, fat injected, washed twice with linear lactate 1 is to 1 ratio with fat for 1 minute. Once the oil, blood cells, and washing solution are drained, remaining fat aspirated with 10 ml Luolox syringe. With 1 to 2 millimeter incision, the collected fat at the border of the scars and with 16 gauge V-shaped needle in Luolox syringe, the fat is grafted after the adhesive lysis of the scar with the retraction of the needle. Incision sutured with Vicryl Rapid and Aristocrat. Sir, regarding the technical details, what are the main technical pitfalls that can reduce fat graft survival and how do you avoid them?
So, so when you're talking about technical pitfalls, first important thing is that the fat cells are very delicate. So they can be easily damaged when we use very aggressive harvesting technique. And when we start at initially improper processing, that means when we do inadequate purification, we don't remove the blood, oil, other debris from this fat that we have to remove. That itself is a negative factor. And then when we try to overdo the thing, when we want to do a very large volume, this thing, the inner part of it, will undergo necrosis, avascular necrosis. So there will be very poor revascularization. So the volumes should be on the lower side. And then other small errors which we don't do at our plastic surgery level, like lack of aseptic technique or poor plane of injections, etc. So we can avoid these pitfalls by, most importantly, first thing is gentle harvesting. Instead of trying to use a larger size, previously we used to use the routine suction machine to harvest also. Then we have come down. Now what we are saying is always use the lowest syringe possible. In this study, they have used 50 cc. Though I'm not against it, but I advise go to even lower. Please use only 5 or 10 cc syringes to harvest, to create negative pressure and harvest the fat. And then proper processing. I personally am happy with decantation. Right from the starting, I used it in between. I have gone to centrifugation technique, but I did not find any huge difference between these two. So now I prefer only the decantation technique for 15 minutes. I'll keep it undisturbed, and after that, I separate and use what I routinely use. And then other things are, most important thing is when we are not specific for this adherent scar, but as a routine thing, always use layered multi-planar fat grafting. Whenever we want to do fat grafting, let it be the breast, let it be the face, or even if it's a scar, if we have that opportunity, please don't try to put it in one plane or one level. Try to put, suppose if you're doing it in the breast, try to put it just underneath the dermis, subcutaneous, something low. If you're doing it on the face, just underneath the dermis, a layer below that. So we are creating maximum contact surface area for the fat we are injecting. So the chance of survival of the fat that we are injecting increases very much. That is the whole point of this.
Okay, sir. Okay, sir. Sir, how important is the choice of donor site for fat harvesting?
Uh, yes, I think it is very important. Previously, we did not give too much consideration to the specific thing, but now uh, I personally use the abdomen or the thighs when I'm harvesting the fat. Literature says that abdomen gives more amount of viable fat cells. But I personally use either the abdomen and the thighs. In the thighs, because of less risk, etc., the lateral thighs are preferred by some surgeons. But I personally say the fat from the medial thighs is soft and we can use it more efficiently in areas like face, neck, etc. Whereas the fat on the lateral thighs is little bit more fibrous in nature compared to the medial thigh. So my personal choice is abdomen followed by medial thigh, followed by lateral thigh.
Okay, sir. Does the filtration technique meaningfully change the biological quality of the graft compared to centrifugation?
So as I was saying previously, there are multiple studies still need to be done. Personally, in my experience of limited number, I personally am happy with the decantation technique compared to centrifugation also. But obviously, with newer technologies coming into the fold, I hope that even much more studies will go on and we'll know much better results in the future.
Okay, sir. So, outcome measures, scar area of interest photographed within 24 hours pre-op, post-op multidisciplinary measure, not to use moisturizer or remove pressure garment before 30 minutes of examining the scar. Subjective patient and observer scar assessment scale was used. 5 locations within the scar was measured and averaged. Control normal skin, contralateral side or adjacent to scar. Cutometer scar with cutometer scar probability 6 millimeter probe vacuum within the probe was used to measure the vertical movement of the skin. Elasticity and skin extension was measured. In DSM-2 color meter computes on erythema and melanin index. 6 millimeter probe, 2 light beams emitted in scar and normal skin. Score shows disparity in vascularization and pigmentation between scars and healthy skin. Statistics sample size 34 patient based on Jasper et al. Study. Dropout rate 10%, minimum 40 patients included. Data tested by Shapiro-Wilk test. Descriptor statistics 6 age, scar location, and causes. Analysis was done by paired t-test. P-value less than 0.05 is significant. Result baseline 46 patients were choose 21 male, 25 female. Mean age of them was 47 plus or minus 13 years. Post 12 months measurement was done in 39 patients. Scar age 20 plus or minus 17 years. Causes burns 57%, necrotizing infection 26%, trauma or other causes 17%. Abdomen fat harvested around 79 ml. After filtration, remaining fat 43 ml. Mean fat injected 22 ml per scar. The key results is significant improvements at 12 months. Pliability is decreased from 7.4 to 5.8. Pain, itch, color also improved. Mean patient observer study score improved from 5 to 3.9. The clinician reported result pliability improved at 3 months but not significantly at 12 months. Pliability improved from 5.2 to 4.6 at 3 months. 12 months, no significant improvement. Other patient observer study, no significant changes at 12 months. Objective measures, cutometer and color meter used. Cutometer, no significant changes in elasticity or extension at 3 or 12 months. Color meter, erythema or melanin differences decreased at 12 months, but statistically not significant. So, in research, why do you think there is often a gap between patient-reported outcome and measurement in scar studies, sir?
So this it is always said that when we're talking about any cosmetic thing or for scars, there's always a difference between what patients perceive and what we as doctors perceive. But one good thing about this study is that the observers, the doctors are more or less satisfied compared to that of the patients. So it says about the integrity of the observers also. And given an option, it is always better if the patients are more satisfied than us.
Okay. So, what is the ideal method to compare filtration versus centrifugation outcomes, sir?
No, this study is very good study. All the things that they have taken into consideration is very good. The only thing that we can add on is maybe because it is a single center study of around 40 patients with 34 numbers, this thing. Maybe now we can use it as a base and maybe multiple centers we need to do and we can increase the number, maybe 100, 200, etc. So even more reliable findings, results we can reach on. But otherwise, I think study was done perfectly well.
Okay, sir. In discussion, a patient reported significant long-term improvement, especially pliability. Principal improvement, pliability more improved than color, itching, and pain. Objective or clinician report no significant long-term change compared to previous centrifugation study. Filtration less noticeable improvement. Possible reasons: baseline scar differences, technical variability, and patient sample. Previous study scar pliability Q2 meter more than 20% improvement after autologous fat grafting at long-term follow-up. No improvement in current study. Individual patient level previous study pliability 28 out of 36 patient improvement was present. Scar elasticity and scar extension improved. Current study pliability less improved. Elasticity 13 out of 36 patient improved. Maximum scar extension 16 out of 36 patient improved. Adipocyte viability analysis in both studies not done. So regarding discussion, indication for fat grafting beyond scars, where can be used?
Yes, plastic surgeons, we routinely use them for cosmetic reasons, for breast or for post liposuction defects, depressions, etc., or for hemifacial microsemia of the face, or for any other part of depression of the face. When we started them only for post lipo deformities or whatever. But once we started having that expertise, we numbers increased. Now we are starting them using them in other conditions also. We're using, as you were mentioning, we started using them in radiation fibrosis. Previously, these were no touch, no go zones for us. Now, among fat also, what we are using stromal vascular factor, we are starting to use them for as nano fat for rejuvenation, not just for volume increasation like micro fat or macro fat. So there is still a lot of scope for its improvement. I think even further, going further, even more improvements will be there in this technique.
Okay, sir. Do you foresee any advances in fat processing technology that could improve consistency of results?
Hopefully, yes, because when we were doing centrifugation technique and the decantation technique, there was no incentive for the companies to do research on it, etc. Now, newer companies have come, and once they start making money out of it, obviously they will put more money, more research will go into it, and hopefully, at the end of the day, both us doctors and the patients will get benefited. That is what is one drawback for us. For me personally, I'm not able to use any of these newer companies because it has become costly for the patient. In a small town where I practice, I can't ask them to buy. I'm happy with the decantation. It doesn't cost anything extra to the patient.
Okay, sir. What's your personal approach for counseling patients on realistic expectation after fat grafting for scars?
So I don't even promise them 50%. I tell them if you will be happy with 30% improvement, please go ahead with this procedure. That is my standard line to them. Even today also after having done some number of cases also, I can't know for sure for this patient it will be of great benefit. For this patient it cannot be. In my hands, I have seen some very dramatic results. In the same way, I have one young lady just before marriage. I have done fat grafting. After she came back to me after 1 year, the whole of it has gone. So the same technique I have done for the others. They were very happy. I was very happy. But here I don't know why last. So there is still a lot for us to learn in this technique. Hopefully, with this newer techniques, newer modalities of filtration or whatever, maybe the viability of the fat cells, we will learn more and we'll be able to promise much better results. But coming back to your question, I always tell them don't even aim at 50%, 30% is a realistic goal. And when we say aim lower, even if we deliver 50% results, the patients will always be happy. And occasionally, those patients who want 90, 100% results, they will never be satisfied. And at least we can sort them out this way.
Mhm. Yes, sir. So, how do you decide whether to do a single star or versus stage scar treatments?
No, I always give the option of staged treatment to the patients only. I never advise them single stage. Suppose for some reasons like somebody has a marriage in a date or they want to get it done there from abroad, they want to get only one session go. I don't refuse it, but my way of counseling, I always try to counsel them to consider always a stage grafting, and it is more physiological. And as you can appreciate, suppose. If there is suppose for a roughly to give an example, if there's 50 grams of tissue and I inject 30 grams of fat now, after some time it becomes 80 grams of tissue, then I can inject 40 grams more, it becomes 120. There is no point in initial 50 grams of tissue only for me to inject 50.
Hmm.
So always when we keeps on increasing extra volume of tissue there, in the next stage we can add even more, so the chance of vascularization of tissue, everything will be better. Problem comes when we think in financial terms, etc. But there is some beautiful article which says that when I'm in breast augmentation also with fat grafting, which says that anything more than 180 to 200 cc of fat, even if inject into the breasts also, it doesn't survive.
Hmm.
So it is one article, so I can't say for everybody it is that. So then what is the point in injecting 500 ml, etc.? It is better we restrict to 200 ml, and after 6 months or 8 months, whatever, go to the second stage, then inject another 200, 300 ml, etc. So the volume keeps on increasing, we can add even more.
Hmm.
So I always advise staged procedure of at least two, three, four stages, etc. It is ultimately up to the patient whether they take it or they refuse it.
Okay, sir. So the strength and limitation of the study: strengths multi-perspective assessment, patient, clinician, and objective used method. Long-term follow-up 12-month multimodal standardized protocol used. Limitation: non-randomized single cohort study, no histological analysis, possible baseline group differences. So conclusion of that study: filtration process autologous fat grafting, significant improvement in patient perceived scar quality, no significant improvement in objective measure, need for standardized outcome sets and high quality comparative study. References and acknowledgement: original article by Richbama, Daniel et al., Burns 2024, funding by Dutch Burns Foundation, acknowledgement to authors and study participants. And my final question, sir: if we are injecting in a scar, where how do we know the limit? Like when we injected around 20 ml in a scar space, so how do you know when to stop? Any indications is there?
No, basically when we are injecting in scars, when we are injecting it in subcutaneous plane, we just try to appreciate whether there is any color change from, we are talking about a small thick scar. So there we try to appreciate one, the color change. Basically when we can see slightly redder erythema, slightly red color, brownish color skin, once we inject the 2 cc, whatever, it becomes slightly pale. So that is my stop. I stop there. That means beyond that pressure, I may end up causing necrosis of that area. When we're talking about breast, etc., that is a different game. We try to do it until we appreciate with the hands, with the feel of it, whether it's become more firm, etc. Same thing when we go in the face, etc. We appreciate it in a different way. But compared to coming to scars, we don't have that much free space there that we can inject as much as we want. We can appreciate the tightness in our syringe also when we are injecting it, the color change also. For me, when we are talking about any adherent scar like this, after subcision, I can inject very minimal amount only. We can appreciate it immediately with the color change itself.
Okay, sir. Uh, is there, if we inject in the neighboring law normal area, uh, accidentally, any what are the complication we might take? What are the end effect?
No, see, basically, as plastic surgeons, we are used to using fat grafting in multiple areas. We know what precautions need to be taken, whether we are using a needle or whether we are using a cannula with a hole on the under surface. So we take all those other precautions. When we're talking about specific scars, right? So in a scar tissue as such, which is adherent to the bone, etc., the chance of any blood vessels being there, our cannula fat going entering into the blood vessels, everything is nearly non-existent. Only thing is we may end up overfilling it or whatever, and that may cause pressure, like avascular pressure necrosis of some point there. But otherwise, there's not, no, for this particular topic, there's nothing to be afraid of. We need not worry too much. Only thing is the plane. If it is a adherent scar, as this topic we are discussing, our level of subcision or anything is underneath the vein, it is adherent. If it is adherent to the bone, adherent to the cartilage, adherent to the, so our level is as deep as possible between the deeper surface and the superficial scar. So in this particular case, there is not much we need to be worried about.
Okay, sir. Thank you, sir. Thank you very much for your valuable time.
See, let us also thank National Academy of Burns India for giving us this opportunity. And I hope more doctors and ultimately more burns patients will get benefited from us, from
Yes,
this
sir.
particular topic.
Yes, sir. Thank you, sir.
Okay. Thank you.